Hi there, welcome to 212, Exam 1, Part 2. We're going to talk about pharmacodynamics, which is what drugs are going to be doing in the body. First thing we're going to talk about is efficacy and potency. Those are both important concepts. We want to know why we give one drug over another drug. What we want is to give the drug that has the max efficacy. That means, efficacy means which thing is the highest effect a drug can have, or the maximum response produced from that particular drug. If we look on this dose-response curve, higher doses have increased effectiveness until it reaches that highest point. Efficacy is that highest point of the dose-response curve. This can be seen on this picture as the 100 in the y-axis. So right here, this is the maximum effectiveness, going upwards in increments. So you see 25, 50, 75, 100. Across on the bottom you see is the dose, which says units or log dose, which is just a number we're going by to show the amount of the drug, just to get this point across. So what we want to know is that when you're talking to patients and they're trying to understand why you're using one drug versus another, this is why these two concepts are important. Morphine and ibuprofen are both used for pain. Right after a big surgery, morphine may be on the medication administration record, or the MAR. It has a greater efficacy than ibuprofen. Morphine is drug A on this graph here. This type, it works really good for this type of pain. Works good at, if like 1,000 units, it reaches the max 100% maximum response. So if you think of ibuprofen as drug B, and see it's working here at like maybe at about 1,000 is where it hits up to this plateau, maybe just a little more. Okay, so if you think of ibuprofen as drug B, at the 1,000, drug B only can reach maybe 60% of maximum dose response. So that's because we know morphine is a better pain medicine for severe pain than ibuprofen would be. So it's effective up to 60 units, or 60% of the max response. Okay, so if you're looking at efficacy, morphine has a higher efficacy and is a more effective drug for high pain than ibuprofen. You don't always need the strongest drug. If you have a headache, you just use 1 or 2 acetaminophen, which is also Tylenol. You don't use morphine IV. Also, you think about comparing those two with the cost of the side effects from morphine. It can make you stop breathing. It can slow the GI motility and cause constipation, the sedation or drowsiness. Ibuprofen or acetaminophen, both of those have much fewer side effects than morphine. Another way to look at this is going to be potency. So potency is the amount of a drug required to elicit a response. And this says not usually important, because it's really where you have to compare apples to apples with this kind of discussion. So potency is the amount of drug required to elicit response. An example again is morphine versus meperidine or Demerol, which you probably won't be seeing Demerol used much, but both of them have a similar efficacy as an opioid for treating moderate to severe pain. If you give 10 milligrams of morphine IM, the same thing of Demerol to get that pain relief would require 75 milligrams, that same pain relief or efficacy. So for 100% max response or pain relief, there's less morphine given, only 10 milligrams, because it's a more potent drug. And it takes 75 milligrams for the same relief of pain with Demerol. So you just need to understand the difference between efficacy and potency, and that if you're getting the same relief of pain, it doesn't really matter which drug you're getting. It depends on the factors that the provider chose to give you one medication versus the other medication. Okay, so on to agonists and antagonists. The agonist effect, that's where the molecules are going to be activating receptors. The affinity allows for them to bind to those receptors and cause an activity. The receptors are activated. It makes something happen. An antagonist prevents receptor activation. And then a partial agonist is a moderate, it has different kinds of partial intrinsic activity. So it can be agonist and antagonist. So we're going to talk about naloxone and morphine. Morphine has a high affinity for mu, or its letter M, letter U, mu receptors. They're opioid receptors, and naloxone has an even higher affinity for those same receptors, the mu receptors. The activity of morphine when it is attached to those receptors or activating them is to give you pain relief, and the activity of naloxone is to stop any active morphine or opiate. It doesn't have any intrinsic activity. It binds to the receptor and stops activity. So it's going to stop the pain relief from continuing. It's not going to be doing anything else to the receptors because naloxone is on there blocking any active intrinsic activity, whereas morphine actually increases that activity that would be happening. So morphine is an agonist and naloxone is an antagonist. So then, let's see. Then a partial agonist is an agonist-antagonist. It provides some intrinsic activity and latches onto the receptor. Buprenorphine is one that latches to the same mu receptor like morphine does and like naloxone does, but it doesn't have as high efficacy as morphine for pain. It partially activates the receptor, providing some pain relief. So then we have this interpatient drug response. Dosing is based on the ED50, which is the effective dose of 50% of the people. It's a way to do safe dosing. So where the dose required to elicit the desired response is 50% of the patient, that's the ED50. That's what they're showing you right here. 50% of the max therapeutic effect, or of the therapeutic effect. This is where you have to adjust it to your patients. If you have someone who's already received sedation and they have a choice for dosing on pain medicine where they're prescribed 2 to 4 milligrams of morphine, maybe just choose 2 for morphine because your patient already has sedation on board. Or if their blood pressure is already low, do you want to give that new blood pressure medicine because you may want to talk to the doctor, their blood pressure is already so low, they may not need that dose. It's easier not to give medication or to give less than it is to take away what you already gave. So here on this slide, we're looking at the therapeutic effect, the ED50, that's therapeutic effect for 50% of the people. We see the toxic effect, the TD50 for 50%, and the lethal effect for 50% of the people. The thing is that this is good for 50%, like on the therapeutic, this is good for 50% of the people, so think there's 25% of people who are on this side, and then there's 25% of the people on this side of this curve. So what you have to think about are ethnic variabilities, size, male versus female, those kinds of issues. Okay, we're going to talk about drug levels here. We're going to talk about the therapeutic index, the narrow therapeutic index versus the wide therapeutic index. Where the arrow is going from the ED50 dose, which is effective dose for 50% of the people, to the unwanted or toxic dose for 50% of the people, the place between those two on the graph here, from here to here, this is the therapeutic index. So you're going from ED50 to TD50, toxic dose 50. So with the wider therapeutic index, if this dose is 10 milligrams and this dose is 50 milligrams, that leaves you a lot of range for making the dose effective for people. And on the narrow therapeutic index, if this dose is 0.5 milligrams and this one's only 1.5 milligrams. That's a much narrower space of amounts of dosage that you can adjust for a patient. It's very little amount to get to a therapeutic range. So the patients are going to have a peak and trough level done when they're on a drug that's has a narrow therapeutic range. You'll be doing drug levels to make sure what level they're at and to monitor them for safety. These narrow index drugs have a higher risk of toxicity occurring. Some of them are digoxin, lithium, phenytoin, and warfarin. So with generic drugs, let's see, I don't think I'm going to talk about that right now. Okay, we're on to drug interactions, part 2 continued. We're going to talk about types of drug interactions. There are all several types. We can see they can be beneficial and intended or wanted, or they can be undesired and not beneficial at all, and unintended. There's an intensification of therapeutic effects, potentiation or synergism. Sometimes they're made to go with each other and help each other, like the antibiotic sulbactam and ampicillin. Ampicillin can be broken down by an enzyme of the bacteria that's trying to work against, and sulbactam prevents this enzyme from breaking down that ampicillin. So you get better antimicrobial activity with that ampicillin because it can get into the cell and it's not broken down by the enzymes. You can have an increase in adverse effects. Think about aspirin and warfarin. Both of them are blood thinners, although they do this in different ways. But if you have a combination of those two, you are at an increased risk of bleeding, and that can be a problem. It may be prescribed to the patient that way, but it also, you need to be aware that there's an increased risk of bleeding and a potential to really increase the adverse effects with these combinations. With reduction or inhibition of, think of a beta blocker, like a beta blocker that's given to a patient, and if the patient has lung disease and they are using an albuterol inhaler, that's a beta stimulant. So these two things are going to be counteracting each other, and that may cause a reduction in therapeutic effects. A response which is a response that neither drug has as an adverse effect alone by itself, but then when you combine these two items, then you get this other kind of response that's not what you were wanting or intending. With alcohol, you can get certain effects, and then disulfiram, it has antimicrobial effect. That's what kind of drug it is. But if you mix those two together, you get headache, flushing, palpitations, trouble breathing when they're mixed. Alone, they usually don't make these kinds of things happen at all, although some people can have flushing with alcohol, but either one of them alone don't have these listed as common adverse effects. All right, so we're going to talk about some mechanisms of interactions. There's direct chemical or physical. This is with IV drugs. You don't want to see this happen. You get one IV drug in the line, and then when you come along with the second drug, it can create crystals in the line. And then if that happens, the first thing you want to do is disconnect that patient's IVs so that those crystals don't get into the bloodstream. The crystallization means you're inactivating at least one of those drugs that were mixed up together in there. You want to disconnect the IV and not keep running it. Antibiotics, aminoglycosides, and penicillin can inactivate each other. And the IV tube doesn't really do the thing where it changes to the crystals, where it actually feels and looks different in the tube, but you won't get the therapeutic effects with those two combinations together. So flushing the IV well between drugs or giving them farther apart from each other is something you have to do. So being aware of the pharmacokinetics with those kinds of drugs. Also, drugs can change the pH in our stomach and alter absorption. If you're giving two drugs with protein binding, it has the effects potentially for binding and interfering with distribution. You get increased free drugs and increased toxicity. There's also competition with active secretion from the kidneys with two drugs at the same time, at the same site. So there's a competition to be either actively secreted or to just be reabsorbed, and the kidneys can only do so much. You can also see potentiation of effects like morphine acting on those mu receptors for pain, that's mu receptor. It can cause drowsiness, respiratory depression. Well, then if you give lorazepam or a benzodiazepine, which is a benzodiazepine, you have the GABA receptors activated, which makes sedation and also respiratory depression. So that's a potentiation of effects there. You can have a combination toxicity and hurt organs. Two antibiotics that are both nephrotoxic or can be damaging and nephrotoxic. You don't really want to give those at the same time and damage somebody's kidneys. So it's important not to double up on those kinds of medications. Okay, we also have minimizing drug effects. How are we? We're going to talk about that. How are we going to do this? First way is to decrease the number of drugs people take. And who do we think are at greatest risks? The populations that are at greatest risk with taking many drugs are usually the elderly, or people with chronic diseases or 2 or more chronic diseases. They might have to be taking a lot of medications and have many kinds of doctors. Some of them are going to be aware of all their medications, and other specialists or different kinds of doctors might not be aware of those medications. So taking a thorough history of all the medications a patient takes is really important, especially more with those with chronic diseases and the elderly. Making sure you know if they're taking over-the-counter medications and asking them about alcohol use is really important. We want to know a baseline of what kind of kidney or liver function they have. You want to ask about over-the-counter medications. Sometimes patients don't think of those in the same category as their prescription drugs. That's why it's real important to review that when you're taking a medical history. They'll forget that also when you're taking a history, they won't think they have hypertension anymore because they have this medication. It's been keeping their blood pressure low, so maybe they don't have hypertension anymore. But we need to be aware of this when taking a history and take a thorough drug history. Also, when adjusting the dose, thinking about whether the medication is an inducer or an inhibitor. With the elderly, we know that, and those with chronic diseases as well, or illnesses, the GFR is lower, the metabolism can be slower, the absorption is going to be slowed down. Think about assessment and reassessment on these kinds of people. All right, we're going to talk about drug-food interactions with absorption. They can react with medication, like tetracycline binds with calcium, so it won't be absorbed. So you don't want to drink a glass of milk with your tetracycline. That's one we know not to give to kids anymore. With grapefruit juice, remember the CYP450 system in the liver. It can increase toxicity of some drugs because it inhibits or decreases metabolism. There's also drug toxicity, MAO inhibitors, and tyramine. Tyramine, which you get in your diet. When you're taking MAO inhibitors, tyramine doesn't get normally broken down. It builds up and you can have high blood pressure or even a hypertensive crisis. Also, potassium-sparing diuretics and salt substitutes can result in really high potassium. So think about what kind of patient who might get this problem with high potassium, and they might be on diuretics and salt substitutes. To me, that means heart patients. A lot of them are doing those things. They might be taking a diuretic and also be using salt substitute as a diet change to help with their cardiac disease. Vitamin K, also, excessive vitamin K can reduce effectiveness of warfarin. If you're on a steady diet of regular proportions, there's not any need to cut out those kinds of foods like leafy green vegetables, in particular kale. All of a sudden, if you decide you're going to go full out health conscious and become a vegetarian or something, and you're just piling on all the leafy greens and kale and dark green leafy vegetables, that might be something where it's going to interfere with your warfarin and reduce its effectiveness because you've made a big change in your diet as well. A lot of people take over-the-counter St. John's wort, which has some alteration on your metabolism, and it can cause decreased effectiveness of certain medications, or maybe increase effectiveness of other medications. All right, that might be a good place for you to take a little break. We're going to go ahead and talk about adverse drug reactions and medications on the next one. Well, with adverse drug reactions and medication errors, we have some definitions to go over here. The problem with medication errors is that they're very easy to prevent, but we're all human, and so they're going to happen. So side effects is a nearly unavoidable secondary effect produced at therapeutic doses. Toxicity is going to be a reaction caused by excessive dosing. Like an allergic reaction, there can be prior sensitization, and it's an immune system response. Remember with that, with an allergic reaction, it doesn't have anything to do with the drug actions or the effects that that drug is supposed to be giving you, the therapeutic effects. It has to do with your immune system going, whoa, what is happening? So it can take a real small amount of the medication to produce an allergic reaction. Idiosyncratic reaction is an uncommon effect. It's related to the genetic predisposition. Then physical dependence, the body has adapted and you get abstinence syndrome after you take the drug away. There's also carcinogenic and teratogenic issues with those medications that can cause cancer, and those that are very harmful with pregnancy. Remember category D that you shouldn't be taking if you're pregnant. All right, so with medication error, it's any preventable event that may cause or lead to inappropriate medication use or patient harm. These types, the overdoses here at 36% for the percentage with overdoses, wrong drug 16%, wrong route 9%. I did find the FDA reported 41% of fatal medication errors is improper dosing. So that's giving the wrong drug and using the wrong route of administration, accounting for 16% of the errors, and communication errors, also 16%. Let's see. I might have told you that wrong. It looks like 41%, 16%. Communication was also 16%. Okay. The most common causes of medication errors are performance and knowledge deficit. Almost half of fatal medication errors occur in people over 60 and over age 60. So trying to prevent errors, we want to make sure we're given the safe dose. Teach the patient the safe dose. Especially you want to do a lot of teaching. You want to assess your patient for understanding of directions. This is where you might figure out that you need a family member or somebody to really be in control. Use pill containers. Have somebody overseeing that person if they don't understand or are unable to understand instructions or the complexity of some instructions. Sometimes there's look-alike names. The patient maybe has been taking a yellow pill for their heart, and when they come to the hospital, it's a generic pill and it's a different color. So if they say, hey, that doesn't look like my heart pill, you need to take them seriously and just do the double check and make sure that it's not the wrong medication. A lot of times it can be just a double check for all of us so that we're on the right page. Then look-alike names, they're supposed to be using tall man letters so that you are really aware of those drugs that this makes the names look different enough with different sizes of letters throughout the name. Then the wrong route versus like an IV dose versus an IM dose. You just need to be very careful when you're looking at this. Also high alert drugs like heparin and insulin. And then pediatric medications, always get a double check. All right, they categorized this next one. They categorized some errors by the harm that it's causing. And you see down here the colored dots where it says no error, error no harm, error with harm, and error with death. Let's see. And there's this description on the side that just explains what's happening in each of those categories. I just wanted to show you this, that there's definitions, impairment of the physical, emotional, or psychological function or structure of the body. That's what harm is. And then monitoring, it tells you what to do. Observe or record relevant physiological or psychological signs. Intervention, change of therapy, active medical surgical treatment. And then intervention, CPR, respiratory support, doing defibrillating and intubating a patient. So when an error occurs, the first thing to always do is take care of the patient. If you didn't realize that the patient was that sedated and gave them more sedating medicine, the first thing to do is take care of them. Do your ABCs, watch the airway if the patient is just too groggy. Say we gave too much insulin, and what we're going to do in that case is check the blood sugar, watch the airway, do assessments. So back to the ABCs again. Once they're stable, you're going to call the provider and say, this is what happened, this is what I did, this is what I've been monitoring so far, and then, what other things do you want me to be done? It's good to use SBAR when this happens because it helps you really get your mind together. It's much better to just own up to what happened and take care of your patient. Tell your patient, look, I gave you this dose instead, this was the dose scheduled. It should have been this much. I'm going to be doing this, I'm going to be doing that, I'm going to be in here every 5 or 10, 15 minutes, I'm going to be checking your blood sugar. Tell them you've called their doctor and let them know what you're doing, what the doctor said, what he wants to continue with after. So in the light of mistakes being made and trying to be non-punitive, it's always better to learn from a mistake and be able to be safer the next time. And to include the patient in the process is the best because they know we're human, and if you own up and, we made this mistake and this is really hard to tell them, it's really important they know that you're going to be there to take care of them, and you're going to be in there taking their blood pressure every 5 minutes, you're going to be assessing their lungs, you're going to be, really providing really great care and doing the best thing to fix the problem. So that's the better way to go about it when there is an error that happens. This is the end of this part. We're going to do overdose and poisoning on the next slide set. Thank you all for listening.